protocols were responsible. And subsequent risk adjustment was partially able to correct for gender-associated outcomes. We have two hypotheses determining if beta grafting in women has an equivalent to long-term survival benefits like in men, and if beta grafting in women older than 65 has a survival benefit than zeta grafting. The case presentation, we have a 73 years old female with chronic stable angina, with risk factors as hypertension, dyslipidemia, diabetes type 2, no insulin dependent, and former smoker 40 pack year. The medication is enalapril, hydrochlorothiazide, rosuvastatin, amlodipine, metformin, and aspirin. This electrocardiogram, we see a sinus rhythm with a cardiac frequency of 70. We can also see first degree AV block, and we don't see any Q wave from previous infarction. Sorry. This is a chest X-ray. We see a cardiothoracic ratio, a normal cardiothoracic ratio. We don't see no sign of cardiac failure, and we see a calcification of the aorta. As regards the ultrasound, we see a normal left ventricle diameters with a left ventricle diastolic diameter of 37, systolic diameter of 20, a normal ejection fraction of 63, normal wall motion, no valvulopathy, and regard the neck vessel Doppler, we see no significant lesion, which is really important here. Also, when we use beta graft to rule out the subclavian Steele syndrome. This is a coronary angiogram. In fact, we can see here coronary disease. Severe coronary disease with small vessels, which is typical from diabetic old women. We have no left main disease. We have a proximal. We can see a proximal lesion at the proximal of the LAD. We can also see a mid lesion or severe lesion at the mid portion of the circumflex, a small circumflex. As regards this view of the LAD, we can see all the LAD. We can see the proximal lesion. We can also see a lesion in the mid part and the distal part, and we have no lesion of the diagonal. And as regards the right coronary artery, we can see severe lesion at the and a subtotal lesion at the mid part of the right coronary artery, and also we can see a lesion in the PDA. Any comments so far?
So I guess we can pause here a little bit. I mean, those are not the best targets, but they're not the worst targets. I would be curious to see. I mean, you gave us some hints, and I know that Dr. Navia is a premier off-pump surgeon, but generally speaking, for the people with us on the call today, how many would use an off-pump technique in this case? I don't know if we have a voting way. Let me ask, can people participate? Who would do an off-pump? Who would do an off-pump here? Who feels strongly about an off-pump?
Dr. Faisal, Lorena Montes raised her hand. Lorena, you can just unmute your microphone and participate.
I am unmuted. You can't hear me?
Yeah, I can hear you, but there is one person in the public trying to speak. Lorena, you can unmute your microphone and speak.
No, I was just answering the question he asked.
Yeah,
So
correct. Yeah.
I would do it off pump.
Anybody else enthusiastic about an off-pump approach? Okay, well, I guess at least we have one, and maybe Dr. Navia is enthusiastic about an off-pump. What about Dr. Dayan? Victor, would you do this case as an off-pump?
I don't know. Yeah, there he is.
I hadn't had the opportunity of looking very well because I am on my cell phone of the coronariography. Maybe you can put it again, please.
Sure. I don't know.
Can you see it?
Yes, perfect.
Okay.
I understand that the LAD system on the diagonal, it doesn't look very bad. I think, as Faisal mentioned before, it doesn't look, it seems reasonable, the LAD diagonal. Also, the right systems, it seems to be okay. They had a main lesion in the main right, and the distal right, the PDA seems to be okay. The problem is the circumflex area. They're very small disease, small vessels, and the proximal disease, and there's some branches on the circumflex there to pick up the best one. In terms of off-pump and on-pump, we are very, we got experience with off-pump, but sometimes these ladies come with an unstable angina because, as everybody knows, all the patients, all the women, when they have the coronary disease, they have a very bad coronary disease, and also the clinical situation is very bad. And that's, we are not very fond of to doing right away off pump in these kind of cases, to tell the truth. But at least we start with the LAD region, and if it became unstable or the circumflex is intramyocardial or is very small, we convert in these cases. We are not 100% off pump guys, you know. But I think the LAD region and the PDA and the distal right, I think they are a reasonable target to go ahead with the off pump technique, and we'll see what happens with the circumflex area. What do you think, Faisal?
I think it's reasonable. If this patient presented here at the clinic, I would say that 100% of the surgeons would go for an on-pump approach, although we do off-pump. I did one yesterday, but knowing my colleagues in our practice, we would go for an on-pump approach unless you give us some information to suggest a really bad ascending aorta or another reason why we should avoid the pump in this situation.
One question,
When you
Daniel.
decided, Faisal, to go, why you decided to do the case off pump, the one case you mentioned?
It was actually colleagues of mine who just started recently at the clinic, and he knew he was going to find a bad ascending that was calcified. There was no atheromas, but it was calcified. And I thought that we could use an epi-aortic ultrasound and strategically cannulate and clamp. But when we went in, it seemed like it's not a good idea. It was just not safe or not the perfect solution to do that. So I told him, let's just do off pump. And we did it off pump, and the patient did well. It was a tricky case because he was a guy with a BMI of 42, very fatty heart, and diffuse disease. And the heart was deep, and the suction cup on a fatty apex wasn't optimal. But we were able to do it, and he did fine. But that was the reason. It was a bad ascending aorta.
You think that there's a description by Lima, as a Brazilian doctor that very famous, started with off pump a long time ago. The very famous stitch, Lima stitch. That you can, I'm sure you know that. You put in the back of the heart on the pericardium and pull up and
Yes.
twist the heart towards the right side.
Yeah, we used all the tricks. I actually remember vividly the video that you showed, Daniel, at our meeting in Argentina. And I used that stitch and I opened the right pleural really wide. The problem is he's so fat and he's so deep in his heart. I mean, you get some fat people with less fat on the heart and less deep of a heart, and you can still manipulate it well. But it was just so deep and so fatty that it made it painful. I mean, we did it, but it was painful. So I wish you were with us to guide us.
Okay. Now, Faisal, how is the clamp time and the pump run time for the cabbage at the clinic right now for 3-vessel disease? How long is?
Well, it depends. If you're doing multi-arterial, it's a little longer. If you're doing veins and lita, I would say it depends on the targets. It depends how much you let the resident do. But we aim for, we like it when we have an hour of pump. We do a single clamp. So it's usually a clamp of just under an hour and a pump time of an hour for a cabbage times 3. That's a reasonable target to shoot for. Now, if you do 4, if you do 5, if you let the resident do more, then you would accept an hour and a half. But we get really, we get a little edgy when we are above an hour and a half on pump. We shouldn't, unless we're doing a concomitant procedure or an endarterectomy or something more involved.
Okay, Victor, how is your pump run for the 3-vessel disease? The question that I ask is, after we start for off-pump surgery, and also our percentage of X2A in the OR have been increased in the last 10 years. But from the beginning, when we switched to off-pump, we recognize that the patients are different in terms of body edema and inflammations, general inflammations. And we are really convinced that 4 hours after the patient out of the OR in the intensive care unit, the patient is totally different when the patient were put on the pump. I think this makes a difference, and that at least is our experience. I don't know what you think about.
Yes, our time approximately, we don't do proximal anastomosis in a single clamp. We do the partial clamp. So our aortic cross clamp time is approximately, for 3-vessel disease without any trouble, is about 40 minutes. So, and then you let's say 70 minutes totally, or 60, 70, something like that, of total on pump time. And yes, I agree with you that the management of fluids in patients that go on pump is a little bit more demanding in the post-op that in patients that are on off pump. But since we have very selective criteria for doing off pump in our center, we do very few cases off pump. We have a selection bias, so that is a little bit difficult to apply and to argument on behalf of off pump in our case.
I wanted to mention something. I recently finished one work from our LACES group. It's about off-pump patients with ejection fraction under 30%. And we absolutely see what Dr. Navia is mentioning, that actually the postoperative fluid management is very challenging in patients with reduced ejection fraction. And that's actually one reason why we found a very impressive, actually, survival benefit for patients with reduced ejection fraction with off-pump surgery. So, like, just trying to adhere to your comment. And I also wanted to mention that actually in Leipzig, we kind of perform 50% of the cases off-pump and on-pump is common.
You know, sometimes it's different. When you select a high bias selection for the patient to go off pump, sometimes you don't have a learning curve to keep all the tricks that to manage the off pump. In other words, when you are doing once in a while, it's difficult to get to get all the experience. Sometimes you have to go to a learning curve. We did that in the past, and sometimes it was painful, sometimes it's difficult. But after you manage all the tricks, it's a regular cabbage for everybody, and everybody can do it. And that's why my concern when you decided to do once in a while, sometimes you are not well trained for all the tricks, and maybe you forget how to manage an off pump once in a while. That's my concern. That's why we started doing not 100%, but almost more than 90% of the cases is off pump, and we are, we have all the tricks very, very used to do that every day.
I think you bring up a very good point, Daniel. I do mid cabs, and I do probably off pumps at enough frequency to feel comfortable, and that's why I scrubbed in with my colleague who doesn't do off pump that often. But I totally agree with you. Every now and then, I just decide to do a multi-vessel cabbage off pump. And actually, what I love about off pump is that sizing, especially when you do composite grafts, sizing of those conduits are perfect off pump. On pump with the hard decompressed, it's always hard to get the perfect length. And actually, sometimes I size my arterial composites before I go on pump, just to get the length perfect. But whilst we're on the topic, you probably are aware of the recent JAMA paper that was by Elizabeth Whitlock that showed that there was no difference in neurocognitive decline and memory loss between cabbage or PCI, but that patients who underwent off pump suffered a decline in memory with time. And they assigned the blame in their discussion on incomplete revascularization. Presumably, I guess they're thinking about heart failure causing end organ problems and memory loss. But I thought that the reviewers and the authors should have included the selection bias, because maybe those who underwent off pump, like my patient, had a bad aorta, a heavier atherosclerotic burden, and that's why off pump was used in the first place. It's just an FYI. It kind of relates to our discussion.
Yeah, okay. I think if you have any comments, Mateo, or somebody else who would like to make some comments, otherwise we can proceed.
Yeah, please go ahead. I will let you know if somebody raises the hand or Dr. Faisal.
Okay, I think for the educational purpose, we're gonna show a video that Faisal mentioned before, and to show all the details for everybody to show how we do it. I think Michael's gonna do it, the description of the surgical procedure that we perform every day here in Buenos Aires.
Well, we're going to show a representative video. Well, that was the score. This the video of the technique, of the surgical technique we use every day here in the institution at ICBA. We almost experience of 4,000 cases. We use beta for most of the patients, up to what, 90%, most of them. Here's the technique. We use the skeletonized technique for both Lita and Rita. We preserve the distal bifurcation and to the proximal part of the artery. We go to the subclavian vein. We also take into account the phrenic nerve not to harm. That's how the pericardium is open in a tick technique, an inverted tick technique. We open the pericardium to the right part, to the inferior vena cava. This is very important because when we are going to lift the heart in order to expose the lateral wall or to expose the circumflex artery, it's very important to maintain the hemodynamic stability. We also open the pericardium to the left part, into the apex. Also, being aware of the phrenic nerve. And finally, we open at the base of the pulmonary trunk. That is where the Lita is going to enter the pericardium. This is very important part of the surgery, so we avoid any kind of kinking or problem when we're doing the anastomosis. Here we place the Pericard stitches. They are very important to the traction when we start doing the anastomosis. 3 Pericard stitches. Then we length the LITA to the LAD, and we measure we're going to do the first anastomosis, that's the LITA to the RITA. That is also at the base of the pulmonary trunk. Now you're going to see an image, almost where we place the anastomosis. We do this anastomosis with a 7-0 Prolene. Like I said, this is the critical part of the surgery because the rest of the anastomosis or the graft are going to depend on this anastomosis. And we use the CO2 for blowing, almost 5 liters per minute. Yes. Then when we start doing the anastomosis, for first anastomosis is the LAD. We place a gauze or a sponge beneath the heart in order to bring the LAD to the middle, and we extract the Pericard stitches. We use the stabilizers, and to maintain the blood flow, or to obstruct the blood flow, we can use a tourniquet. It depends on the surgery preference. With a 4-0 Prolene, or if the patient have a chronic total occlusion of the artery, which we have reverse flow, or if we have a severe left main disease, we prefer to use shunts. We also do the anastomosis with a 7-0 Prolene, or if the vessel is too small or too diseased, maybe we can use a 8-0 Prolene. After we finish the anastomosis, we check all the graft with the transit time flow measurement in order to check the flow and if there's any resistance or any problem with the graft. Then we lift the heart. We consider how the right ventricles enter the right pleural space in order to gain stability. And we measure the RITA to the circumflex, and also taking into account the LITA artery to avoid kinking. This is very important. This is a picture. And now we also use tourniquet, and we use this anastomosis in a diamond shape. We make this anastomosis.
No, pues yo tengo que haber visto el artículo de las 10 cosas. Esto dice que no lo pasó.
Most of our patients receive sequential graft. We check the flow again when we end the graft. And finally, the last graft is the distal part of the right coronary artery. We do an end-side anastomosis with the RITA, also using a shunt or a tourniquet. This is how we check for all anastomosis. We check there's no kinking. We check there's no bleeding, and there's no tight for the graft. well, that's most of this thing surgery.
Okay, any comments? I think maybe some comment regarding the sequential grafts. Everybody likes that, or any comments about this technique, Faisal or Victor or Mateo, whatever?
I
I have a question
Yeah.
or a comment. Sorry,
No.
Mateo.
No, please go ahead, Victor.
Yes, just to spark some discussion regarding this. In the last couple of years, I happened to do quite a lot of BMAS with Y configuration, and one or two times I had the disappointing result of competitive flow using this technique. And it's like we have a saying here in Uruguay: si te quemas con leche y ves a la vaca llorás, if you burn yourself with milk, you see the cow and you cry.
Victor,
yes.
How you recognize the competitive flow?
So I had, for example, a bad flow on the RIMA going to the lateral wall. And when I clamped the lima that went to the LAD, the flow improved to the lateral wall of the RIMA.
The runoff of the anastomosis was okay? You think it's not a problem with the runoff of the runoff is a small vessel? Like maybe this is the problem.
No, because that could be a possibility, but the thing is that when I clamped, for example, when we generally, I do that always when I don't have very good flow. In the cases in which we don't have very good flow, I clamp the lima that goes to the LAD. And if I have a good flow, let's say above 25 milliliters per minute and a low PI, I assume that my distal anastomosis is okay and the issue is with a competitive flow. So my question is there any situation in which you might doubt using a Y configuration and therefore to have independent revascularization for each of the distal anastomosis?
Repeat, Victor, because Vrancic is going to answer this question.
Yes, so whoever, or you, Navia, or your team, or Faisal, maybe, my question is the following. Is there any situation in which you avoid using a composite Y graft in order to, in case you are frightened of having competitive flow? Let's say, I'm going to put an extreme example, a 90% tight LAD with a very good distal vessel and let's say a 60% or a 70% obtuse marginal with a very bad runoff. In that case, I would personally, let's say, okay, I will not do a composite graft because I will be afraid of having competitive flow and all the flow going to the LAD and in the effect of the obtuse marginal. So my question is there any situation in which you doubt using a composite graft or you just do it the same to every patient?
Okay, I think that there will be a competitive flow if you have a 60% lesion anywhere. So we use this type of anastomosis when we have or when the patient have or has severe obstructions. We have the flow measurement probe, so we can make any change if we have competitive flow, but we don't use or we don't doubt to use this technique if the patient has severe lesions.
Well, my question might be connected to Victor's question. Is, let's say you have a patient and you cannot operate on pump because, for example, a porcelain aorta, so you decide to operate off pump, but the distal vessels are very bad, and you don't really find good vessels to do a good anastomosis, and you only have the LID. What do you think about only revascularizing the LID in those patients? LITA to LID, and that's it, even if they have 3 vessel disease. So you can do it off pump and just 1 vessel, and yeah.
We can send it to the Cleveland Clinic to do this case, but now here I think we can do that but it's difficult to open the chest just thinking for 1 vessel only. Sometimes we put on the pump without clumping and decompress the heart, and then we ensure more stability, and the anesthesia guys are more quiet, and we have plenty of time to dissect all the vessels proximally, maybe sometime intramural, intramyocardial, and this is sometimes we use that. Also in patients that became unstable with chest pain in the last 48 hours, we don't hesitate to go on pump just to support. We had some EKG elevation enter in the OR. This kind of patient, we are not so fanatic to do off pump in these situations. We put on the pump without clumping, and we decompress the heart, and it has been very useful, this alternative. In case of we had to do LAD, we had to do LAD, but it's very disappointed. We are pushing to do the first things, complete revascularization, and the most important things to be comfortable that the quality of the anastomosis is perfect. That's the 2 main concepts that when we switched from on pump to off pump. This scenario were very emphatic to preserve that concept, just perfect anastomosis and complete revascularization. It took us a learning curve to reach that point, but we are plenty confident now to do that. Perfect anastomosis and complete revascularization, these are 2 main goals that we have preserved in the last 15 years. That's for sure. It doesn't make any sense to do off-pump technique without not good anastomosis and without reaching all the target vessel that the patient needs. These 2 concepts, these 2 goals are very important, no matter if you're going on pump or off pump. That's the goal concept for coronary surgery that we have to preserve.
Can I make a question to Faisal? Maybe Faisal, you can take the opportunity to do a brief comment on your paper at JAC that was really excellent regarding the dominance of the LED, and when you have different type of dominance of the LED, when should we do additional arterial graft to the lateral wall and when not? I think it's a good opportunity for all of us to learn of your experience in this.
Yeah, thank you. So what really prompted this is reviewing lots and lots and lots of angiograms for multiple studies that we published here at the clinic. And then also a personal experience. My dad, who's 87 now, is living on a patent LITA to LAD with all his vein grafts down 30 years after a CABG. But my dad is lucky. He has a hyperdominant LAD that wraps around the heart and supplies everything through collaterals. And I remember I sent his films to Dr. Lytle 15 years ago when his last vein graft went down. And I said, Dr. Lytle, what would you do? And he said, I would sit tight. He's going to do just fine. Well, thankfully, he's fine. He's 87. He still goes to clinic. He's a dentist every day. So in my mind, if you have a hyperdominant LAD, you probably don't need anything else. You probably shouldn't take the RITA. Why waste a RITA when it's not going to make a huge difference? But on the other hand, not everybody has the anatomy that my dad has, because many patients have an LAD that reaches the apex of the heart, but they could have an OM that reaches towards the apex of the heart as well. And I call that an important vessel. Any vessel that reaches greater than 75% towards the apex of the heart should get ideally a second mammary or a radial if you believe in radial. And there are situations, not very common, where the LAD barely or even doesn't reach the apex, and you have a huge OM and a huge PDA that do reach the apex. In those scenarios, I would put a Lima to LAD and put arterial grafts on both other targets, kind of like what this case was all about. And it turns out that, and we haven't conclusively proven it, but it seems like we have a dose-response relationship between arterial grafting and myocardial mass supplied, and a saturation point is reached once you bypass all important vessels. So don't feel bad if there's a PDA that reaches halfway to the heart, apex of the heart, and you didn't put an arterial graft. You're not going to impact survival. So that is, in essence, what guides our practice now. So a difficult situation, and I'm going to ask Daniel or Victor, is a situation whereby you have a really tight LAD lesion and you have a 70% PDA lesion with an important PDA. And then you do this composite configuration. Notice that the Rita is longer beyond the branching point than the Lita. And this is a situation where the patency of that limb is at jeopardy, the Rita, because you're bypassing it to a vessel that's only 70% compared to 99, let's say the LAD, and you have a much longer graft. This is at risk for imbalanced flow and at risk for that Y graft to maybe not last for long.
We published that a long time ago in Annals. We cath 250 patients in the post-operative period. It was difficult to cath the guys, but it was we had the intention to do it because we need to in some way figure out what's happened with all the grafting or this kind of scenario with these configurations. And as Faisal said, our experience with the distal right, the permeability was lower than the circumflex on the LAD. It was lower than for sure in terms of percentage of open, around 80% or almost higher 70s compared to the 90% of the circumflex and also in the LAD regions. This is one of the, I think, the kill heals of this technique. I think if you have a big PDA or the lesion is the main right and the distal right is important one, this is scenario is tricky, and you can jeopardize the right area, the right coronary system with this technique, because sometimes the IMA also in women's, the IMAs are very small and fragile, and also the distal tip of the Rita is very small. And this is a very demanding area, and maybe this is a kill heal for this technique in these scenarios. In the past, we don't hesitate to put a vein there if the lesion is in the main right, because for sure we understand that the flow, the distal flow of the Rita after the circumflex diamond shape anastomosis, maybe is not good enough. That's why in this scenario, they're not very frequent, because also the majority of the times the distal right is the disease. But when the main right is the tight lesion in the main right, but the distal right is not diseased, sometimes we use directly a vein from the aorta or radial from the aorta, just a direct graft to the main right system instead of to the PDA with the distal Rita. Always in women is very difficult to do it. And I agree with that.
So Daniel, I want to learn something from you today, because every time we meet, I learn something from you. So I'm going to ask you two questions. One is, any tricks when you're doing on pump, how to do the lengthening and the length of the grafts when you do a composite, and how do you determine where you put your Y, intrapericardial? I usually do it intrapericardial. What's your preference, and what tricks do you have for those of us who do more on pump than off pump?
we try to make the Michael said that's very important. When we make the V section of the pericardium, keeping track of the phrenic nerve, we're going just close to the phrenic nerves, around 1 or 2 centimeters away from the phrenic nerve, and we put the LAD inside the pericardium cavity without touching the heart. Just let the heart beat. In your own palm, you feel the heart and try to reproduce the situation when the patient is not in surgery. And immediately when the LITA entered to the pericardial cavity, maybe a centimeter after the V shape that going through the pericardium, this is the site of the anastomosis, the LITA Rita. It's inside the pericardium, because this maneuver is very important, because you get some distance for the PDA in the long run. You have the entire length of the Rita with this technique. I think the place to do it, the Y graft, is intrapericardial, and then we had to do it in T graft and not in the Y graft. In the T graft, to preserve more distance for the distal vessels. I think it's always is inside. When you are on the pump, you feel the heart and try to reproduce the volume of the heart and try to get a good place to reach a good place for the anastomosis. But this is a critical scenario. Sometimes when you do the perfect anastomosis and you are secure to do a good LAD and good circumflex, but it's not reaching the PDA, this is also a very special situation. And sometimes we get a distal part of the LITA and we anastomose with the 8O and the distal Rita to have more length. And sometimes we use in the past a Rita 2-3 centimeters of Rita, I'm sorry, for the radial artery. And in the last couple of years, we use just 2 or 3 centimeters of a vein. And we prolong the Rita. But this is a special situation, not every. If you keep all the details in terms of where you place the T graft, you have a plenty of length to do circumflex. Sometimes you can do 2 circumflex and reach the right. It depends on the artery, and sometimes always the women's are difficult, are more demanding. But this is a concern that we recommend.
So Daniel, just a follow-up question. I've found out through trials that, and errors obviously, that probably the best place. First of all, you're right. I like a T rather than a Y, unless I'm going to a high diagonal or a high ramus. But I use a T graft. I noticed that you did a T graft, but you beveled your Rita. So that's kind of similar to my approach. And this anastomosis usually occurs at the pulmonary valve level, so that this Rita comes off as if it's coming off the aorta. That's the lay of the graft, and that's usually how I end up with a satisfactory configuration. Is that also your experience? Is it about just above the pulmonary valve, and you do more T grafts than Y grafts?
Yeah, we're doing definitely T graft on everybody,
Yes.
and pulmonary valve, or also the left appendage. The projection of the left appendage towards the surface is always a good place to recommend to do the anastomosis.
Yeah, perfect. We're on the same page.
Okay.
Dr. Faisal, there is one question in the public from Lorena Montes from Colombia. Maybe Lorena can ask herself. It's about the intraoperative graft measurement or the flow measurement, because I mean, I guess you have it in Cleveland, and I saw you have it in Argentina, but it is not available everywhere in Latin America. So maybe Lorena, you can ask your question yourself.
Yeah, hi. No, I was wondering how many services, cardiac surgery services in Latin America have the flow meter available, because I know in Colombia it's not that easy to find. So I was wondering that. And in the same order of ideas, I wanted to ask Dr. Navia, if before he had the flow meter, what did he used to do to verify the quality of the graft?
Here in Argentina, thank you for the question. Here in Argentina, there are a few equipments, no more than 4, I think. They're not very popular here, and also they are expensive. In the past, we get the first version of the equipment a long time ago, 12 years or 13 years, something like that. And before that, now we pray, I think. Now we see the AKG, we see the Doppler. Sometimes we use the Doppler for the, the vascular Doppler. Sometimes we sterilize, and we had to check all that. And as soon as we get the equipment, we are very pleased for that. We convinced the administrator to buy this equipment, and it was a very important tool for us. And lately, we got the last version of the equipment that we had a Pro, Echo Pro, ultrasound Pro, that you could put over the anastomosis, and you can see not only the diastolic flow, and also you had an image for the flow is going antegrade or retrograde. Sometimes you had a perfect diastolic flow, but it's only retrograde, and antegrade is not correct. This was helpful. It's easy to manage the ultrasound probe in the anterior wall. Sometimes it's painful to do in the circumflex or the distal PDA. But I think it's a very important tool to do also when you're doing on pump, because sometimes to do all arterial grafts, they are tricky. There are some spasms and some also different, and it's a double check. I think it's a good technique. We check all the anastomosis, and very often we had to go back and redo the anastomosis. It happened many times. And when when you don't have this this equipment, it's difficult to recognize that sometimes it's difficult to recognize that the anastomosis is not perfect.
Dr. Navia, you know both worlds, and you have the experience before the device and after the intraoperative measurement. Do you notice a real clinical improvement in the outcomes besides redoing the anastomosis? But do you notice in your experience a real improvement in the clinical outcomes with the intraoperative flow measurement?
No, I don't think so. I cannot answer the question, but this is a quality tool to perform a correct anastomosis. You always, when we're doing off pump, sometimes stability, visibility, hemodynamic stability, and how you approach to perform anastomosis when there's a small vessel, you have to do 8-0, and the anesthesia guy is very anxious. There's all the scenarios that is important to have a good measurement of the flow, before the patient going out of the OR. I think it's a good tool, and if you can reach it, if you can obtain it, it's very important. It gives you a quality of performing the coronary grafting.
Well, any comments?
Mateo, I have a question.
Okay.
When you do the measure of the flux of the anastomosis and it's bad, and you try to do again, you try to do again off pump, or you prefer to go on pump?
No, we're doing off pump. If the patient became unstable, he fibrillates, or the EKG is all the way up, we have concern about that. We have the TEE showing that one of the walls, the anterior wall, lateral walls, or they had a mitral insufficiency because of the ischemic on course. We can put a patient on pump in this situation, but not because of the anastomosis, because of the ischemia that the patient has. If the problem is the anastomosis, that we identify that the anastomosis is not correct because of the Doppler or whatever, or we understand that the color of the arterial flow is not adequate, we are going to do it right away off pump. But the patient became stable, the patient became fibrillated, because the patient on the TE had some abnormality wall motions. Well, we go in on pump sometimes. We have to do it. It's not a problem.
Thank you.
Yes. Well, we continue. And the first, the only case. Well, the surgery treatment from this patient was beta of pump. We made a LITA to LAD and RIMA T-graft configuration to circumflex and distal right coronary artery. These were the flows. Here we have the flow for the Lima LAD. We have 22 of flow, PI of 2, and a diastolic flow of 74. Then we have the RIMA, a flow that it was 9 milliliters, but then we repeat and improve. It was a PI 3.8 and a diastolic flow of 50. Yes, but we do it again here in the RIMA CX. We repeat the flow in the RIMA, and it was 66, and a PI is 0.9, and a diastolic flow of 66. And also when we finish doing all the graft, then we pass the protamine to the patient. We reverse the patient with protamine. We repeat the flow or the flow measurement to the Lima, to the proximal LITA, sorry. The patient recovered with no complications, extubated the OR, remained in the ICU for 24 hours without inotropic drugs, discharged on the 5th of postoperative day.
Entonces, déjame directamente, porque ya es una hora. Sí. Vamos a presentar lo que trabajamos nosotros. Y...
Sí.
We got an hour already. We got 2 or 3 slides that we share with you, the paper that we published with Mariano Vrancic a long time ago regarding the sex and gender and the beta against theta. One of the questions that we mentioned, Michael, we had to keep the mean blood pressure around 80 to do all the flow measurements. This is very important. And also before and after the protamine injections. Mean 80. Otherwise, you had maybe lower flows and you think that there's any problem, but the problem is they're very sensitive to the blood pressure. Okay, go ahead. Vamos adelante a mi presentación. Okay, this is a slide that will show you what the context relations over time. As I mentioned before, we started with doing radial artery, and then we decreased that. And in the last years that you saw the slides, we switched to 2IMF. This is our results. I'm very pleased for that. Have been published before. And the thing that I want to mention is what happened in terms of the sex risk factor for death in patients with bilateral internal thoracic artery graft that we published in the GTVAC in 2019 again. And this is to a hypothesis that were mentioned before, that we intended to determine if the beta grafting in women has an equivalent long-term survival benefit like in men. And the second hypothesis was that the beta graftings in women older than, we put age also as an independent predictor, more than 60 years of old, has a survival benefit than the theta grafting. For that study, we made a retrospective analysis for the entire cabbage population by that time, and we identified beta grafting 2,900 and as a T-graft, and then the theta group was 1,400. And in both groups, we divided in terms of women's in men's. And for the first analysis, we compared beta grafting, compare men and women. You can see there, men were 2,600 and women's 299 populations. All these are the patient characteristics. You can see that sometimes in terms of the risk factor, sometimes non-elective surgery, non-pump was more frequent in females, and also pre-myocardial infarction, pre-PCI was most frequent in males, and also the women have more peripheral vascular disease, more anemia, compared to the female, compared to males, and smoking history most frequent in males, And also age was older. The women that were older, significantly older, 67 is the average age, and 63 for men. Number of vessels 3.2, 2.9, more less vessels in the disease and female, and also the body surface area is lower in the female, as everybody knows, and also graft per patient was significantly lower in the female. This is for the unadjusted populations, and when we are risk adjusted for the entire group, all these variables and difference disappears. In terms of the result adjusted and risk adjusted, you can see there the death and the stroke, 1.3% in female, 2.3 in death in female compared to male were significant. And also mediastinitis also was more frequent than female compared to male, significantly. When we're going to risk adjusted with the propensity score, only mortality was closer to significant 0.05, and all the early outcome was pretty similar between female and male. What happened with survival? In survival, male and female with the beta grafting were comparable. There was no significant difference at 10 years in survival compared when we're doing beta in male and in female. Again, and also when we're doing a matched populations, also again there was no statistical difference. In other words, females behave at the same and male and with beta grafting group a 10-year survival. In the second hypothesis is we thought that the beta grafting was compared to theta grafting better in women in terms of survival. Then for this analysis, we select these two populations that there is in the slide, woman 299 and theta group 207 women with the theta graft. Mainly some literature to LAD and veins, and some groups have some radial to the circumflex. This is all the patient characteristics. This is a busy slide. It's difficult to identify, but the most important is again the curves. This is the mortality, theta and beta. You can see there is kind of increased. It is a retrospective analysis. One of the limitations that all this analysis, because the theta group was early in the experience around 1996, 1997, 1998. That's what's difficult to compare again. And when we check for the 10-year survival for our group, for the entire population, the woman for beta grafting had a significant better survival than the theta group again. And also when we're going to the matched group, again, 0.01, the woman with the theta with the beta grafting had a better survival than the theta group. Also, when we put we analyze what happened with the older women, and we identified that the more than 65 years old, they had no difference in this scenario with the entire group. But when we put the more than 65 years old, you can identify that beta grafting group compared to the theta in women seems to be that the beta grafting patients had a better survival than theta. This is another conclusion. You can see that all the numbers at risk, the patients at risk are very small, but we maybe it's something to think about it, that the beta may be protected also compared to theta in women in terms of long-term survival. As I mentioned before, the limitation of this paper has the data percent in these studies are from a single center, and this is retrospective analysis. To minimize this risk factor, we perform focus record review for extreme data point and confirm genders as a primary outcome, and propensity score analysis was performed. Also, our study will also basis on an historical surgical experience and the changes in the surgical technique over time. However, all the staff surgeons perform the same surgical technique at that time. In conclusion, we think that beta grafting, we have many others in many publications compared to us and also different to us, beta grafting in women was associated with a similar 10-year survival compared to men. And second, the use of beta grafting may improve long-term survival among women older than 65. There's an idea that we can go back and do it at the same analysis. Maybe this true, maybe this not true. But I think doing beta in women have the same behavior at 10-year survival than men. I think it's our conclusion. Thank you for everybody. Maybe you had some comments, Faisal or Victor or Mateo.
I want to congratulate you, Daniel, on our great results. Operating on women is always a little trickier than operating on men. There's a historic paper from the Cleveland Clinic by Dr. Lytle and Dr. Sabik that showed that the risk of mediastinitis in women who are obese, diabetic, with peripheral vascular disease, and smokers of a double digit. So that made them shy away from offering beta grafting in women with comorbidities like that. So your numbers are excellent. The risk of mediastinitis is higher than the STS average, because the STS is risk of mediastinitis is less than 1%, but your series goes back to the 80s, and the STS is just more contemporary. So I think overall, you probably have less mediastinitis in the last 2 or 3 years, probably less than 1%. So I think all the women should go to Buenos Aires and have their surgery by Dr. Navia.
Any other comments?
I just want to make a final comment. First of all, I want to thank Daniel Navia and his team and Faisal for this participation. And I just want to say that I am really proud that in our South American South Cone, we have a center of excellence to which prospective residents, Latin American surgeons can have the opportunity to assist and to see this type of surgeries in a center with really, really good results compared to North American or European centers of excellence. So once again, thank you very much, Daniel, Faisal, and the rest of all of those who have participated in this grand round.
Okay, final comment, Victor. Thank you very much for the invitation for our department. It's a privilege to participate in the LACES. I think the LACES is a very important tool for everybody in Latin America. And everybody is invited to be in our department, to see all the surgeries. I think you're gonna be welcome in Buenos Aires to participate and spend a week with us. And we can send you and tell you all the tricks for this surgical technique that everybody can do it. Thank you very much, everybody. Thank you, Faisal.
Thank you, and I look forward to future collaboration between us and LACES. Please reach out to me anytime, email me or call me. I love to learn from you, and you're welcome to learn from me.
Okay. Bye-bye, guys.
Thank you so much. Bye-bye.
Thank you.